Hey guys, I'm back. So now we're going to talk about acute renal failure. There are 6 questions on the final about this. They have split it up into acute kidney injury, nephrotoxic medications, fluid balance management, and hemodialysis, peritoneal CRRT, complications and their access. There's also a diet section which I'm not going to cover. I feel like there's plenty of other information in this section, and if you guys want to look it up, go for it. So, acute kidney injury is the abrupt increase within 48 hours of serum creatinine resulting from an injury or insult that causes a functional or structural change in the kidney. There are several different kinds. I'm only going to talk about pre-renal because it accounts for 60% of acute kidney injuries, which is significant. So for pre-renal, this results from a pronounced reduction in cardiac output. There's 3 different ways that could occur, so we'll talk about those. We have severe hypotension, which results from systemic vasodilation. This can be caused by sepsis or neurogenic shock. Hypovolemia, this can be caused by diuretics, osmotic diuresis, vomiting, diarrhea, burns, or blood loss. Basically, any way that you can lose fluid from your body is how you can get hypovolemia. Then we have severe vasoconstriction. This can occur because of medications such as NSAIDs, ACE inhibitors, angiotensin receptor blockers, and cyclosporine. It can occur from abdominal compartment syndrome or hypercalcemia. Signs and symptoms of hypovolemia are hypotension, tachycardia, dry mucous membranes, poor skin turgor, flat jugular veins, weight loss or a low CBP or POP. And then sometimes that results in increased extracellular fluid, which is an indicator of decreased renal function. This looks like edema, ascites, weight gain, or increased CBP or POP. And we'll talk about how to treat those in just a minute. So our nephrotoxic medications are your NSAIDs and aspirin. So we've got aspirin, Celebrex, ibuprofen, Indocin. If it's an NSAID, it's nephrotoxic. Any med that is filtered through your kidneys could be nephrotoxic, so they recommend to reduce those dosages as much as possible to avoid further damage. Then we're also going to check our peaks and troughs on vanc and gentamicin and keep those pretty closely monitored when our patient has AKI. Contrast dye, if they need a CT or MRI with dye, we give that sparingly because it's filtered through your kidneys as well. And then we use aseptic technique. This doesn't really fit under nephrotoxic medications, but I know where else to put it. So use aseptic technique because when they have infection, all of the waste from the infection, whether they're fighting it adequately or not, is filtered through the kidneys. So for fluid balance management, we're going to start with the fluid challenge. This is 250 to 500 ml bolus. If it works, their blood pressure, central venous pressure, heart rate, and urine output will become normal. Pretty quick. It said like within 20 to 30 minutes of the fluid bolus. If it doesn't work the first time, we're going to do it a second time. And then if that second time, well, we'll go to that in a minute. While we're doing this, we are going to monitor for some things. We need to watch them for signs and symptoms of fluid overload. So this looks like dyspnea, crackles on auscultation of their lungs, shallow and rapid respirations, distended jugular, increased heart rate. They could have S3 heart sounds and elevated blood pressure, CVP, and POP. So we just need to monitor for those things while we're doing these fluid challenges to make sure the fluid goes where we want it to. If the fluid challenge fails, we're going to initiate a vasopressor. They prefer levo-fed to the others because we're trying to increase their MAP to get their kidneys working better. That's the whole goal of all of this, is to increase their mean arterial pressure to perfuse their kidneys so their kidneys can work. Okay, so now we're going to talk about hemodialysis. We'll start with peritoneal. This is access with a tunneled catheter. Our nursing responsibilities are to evaluate the fluid volume status of the patient, check their temperature, and review their lab values to check for electrolyte balance and elevated white blood cells to see if they have any kind of infection, because that's a contraindication for dialysis. We need to decide if they need an inflow or a drain step start. Inflow means you start by giving them the dialysate, and the drain would mean that they had dialysate left in their peritoneal cavity, and you would start by draining that out. So then after we've done all of those things, we're going to set up the peritoneal dialysis system. I'm going to go through this as if it's manual, and I'll just note when you wouldn't do that step if it was a machine. So we're going to warm the dialysate to body temp. There will be a specified warmer for this. Do not microwave it or heat it with warm water. If it's a machine, it will warm it for you. Like automated peritoneal will warm the dialysate for you. We're going to make those connections aseptically to prevent infection. And then we're going to begin the dialysis. So through the process, we're going to monitor the process, make sure everything's going the way it should. As the dialysate is returning, we're going to measure that return and make sure that it is equal to what we put in. If it's not, it might be like a kinked tubing, and it could also just be the patient's position, so reposition them. While we are measuring the return, we're going to look at the color of the return. We should be able to read a paper through it. If we can't, if it's cloudy, that can indicate infection and we need to call the doctor. Then when we're finished, we're going to disconnect aseptically and place a sterile dressing on the patient's port. And then we're going to weigh the patient. So now we're going to talk about CRRT. This is access through an arterial line. What I saw in the ICU was that they mainly did this through a central line, obviously in an artery, but they did it through this internal jugular instead of doing it through like the wrist. So our nursing responsibilities are continuous assessment of fluid volume status. We're going to monitor vital signs, hemodynamics, and fluid balance every 30 minutes while they're on this. Assess the ultrafiltration rate every hour and administer replacement fluid. And then we're going to do an hourly fluid balance goal. The provider will set that. The one I saw the most often was 0. So they wanted just as much fluid coming out as was going in. And you adjust that every hour to meet the goal. And then we're going to monitor labs at least every 12 hours, but most often it's ordered every 4 to 6. The labs we're monitoring are your electrolytes, your BUN, and creatinine, so a CMP panel. And then we're going to ensure patent vascular access. We're going to maintain this with anticoagulants, but we have to balance this really well so that we don't cause catastrophic bleeding in the patient. We're going to assess the hemofilter for clotting, and since they do have an anticoagulant in the system, we are going to check the PTT and clotting studies as often as every hour, but really as often as the provider has ordered labs. Then we are also responsible to avoid interruptions that are unnecessary and prevent complications from occurring. So complications, we're going to go back to peritoneal dialysis. The most common one with this is peritonitis caused by contamination. Signs and symptoms of peritonitis are elevated temp, elevated white blood cell count, general malaise, cloudy dialysate return, and abdominal pain that is greater on the inflow step of dialysis. This is a relatively easy treatment. They just add an antibiotic to the dialysate and continue with dialysis. For CRRT, there are several complications that can occur. We have hypotension. Our responsibilities, we're going to assess for blood loss. Then we can decrease the ultrafiltration rate temporarily and then step it up as the patient can handle it. Then we're going to increase the vasopressor support and contact the provider if none of these things are working. Then we have hypothermia. You can put a warmer on the blood return line, or you can put a warm blanket on the patient. Either one is effective. Electrolyte imbalances and coagulation abnormalities are also a complication. We do that lab work frequently. This should prevent this from occurring. But if it does, definitely contact the provider. They will change the dialysate makeup and possibly change the coagulation or the anticoagulation meds, and maybe prescribe, the antidote to the anticoagulant that was being used. Something else we can do to prevent the bleeding from the anticoagulation is that we're going to keep all the lines in sight. We're going to make sure that they are securely connected so that they're not leaking blood, because dialysis is pulling the blood from the patient's body, filtering it for them, and putting it back. So for CRRT, the current recommendation for discontinuation is when the patient can produce 400 milliliters of urine in a 24-hour time period with, on their own, no diuretic assistance or anything like that. So now we're going to talk about hemodynamic monitoring. There are 6 questions on the final about this. We're going to start with the CVP, or the central venous pressure. This evaluates the amount of blood returning back to the heart and the ability of the heart to pump it back into the body. We can also evaluate volume status, pulmonary status, right-sided cardiac function, and medication effectiveness through the CVP monitor. So oftentimes this will be placed into a central line through the distal port. To obtain a reading, we're going to level it, zero it, and then when we do measure the pressure, it's going to be at the end of expiration so that that thoracic pressure is not increasing the CVP to make it inaccurate. Your typical reading should be 2 to 6 millimeters per mercury. We use it to monitor fluid volume alteration and evaluate the effectiveness of treatment and assess the impact on the patient. So CVP mirrors your blood pressure. So your low and high CVPs are caused by the same things that cause low and high blood pressure. Like low blood pressure is fluid volume deficit. Well, so is your CVP when it's low. So I feel like we all know that, so I'm not going over it. We'll move on to arterial lines. The radial and brachial artery are the preferred placement, with radial being the most preferred. When we place it in the radial artery, we're going to do the Allen's test to make sure that the other artery supplying oxygenated blood to your hand is patent. So the arterial line has 4 main components. You have the catheter, the flush system, transducer, and monitoring system. We can use the stopcock close to the body for ABGs and other lab draws, but we're not ever going to push medication through your arterial line. It goes straight to your heart. Not a good idea. And to get an accurate reading on your arterial line, you need to ensure that it has been leveled and zeroed. You need to do this at least once a shift, and then every time that you reposition your patient or they reposition themselves, it needs to be done. And to check for accuracy, we're also going to get a blood pressure reading from a non-invasive blood pressure cuff. So a way to check the arterial line to see if it is giving you an accurate reading is the square wave test. So we'll go through the steps of how to do that real quick, and then I will talk about the different types of oscillations that you'll get. So to do the square wave test, we're going to activate the snap or pull tab on the flush device. Then we're going to watch the square wave that will be generated on the device. We're going to count the oscillations after the wave. We're going to observe how far apart they are and how tall they are. And we're going to do this once a shift to make sure we're getting an accurate reading. So over-dampened waves, oscillations, whatever, is just a few small oscillations following your square wave. The underdampened will have lots of oscillations following your square wave. And when it's adequately dampened, it will have 2 oscillations after the square wave, and they'll be about 1/3 of the square wave height. So when your system is over dampened, there's some causes that it could be air bubbles. It could be that the catheter has clotted off, or there could be blood or kinks in the tubing. All of these things are easily fixed. If it's underdampened, you might have too long of a tubing. It could be really excessively long, and you could have too many stopcocks in your tubing setup. So another thing that you'll see is your diacritic notch. This indicates the closure of the aortic valve and the beginning of diastole. So our responsibilities in relation to arterial lines are to assess arterial perfusion pressures, interpret the accuracy of the waveform, and troubleshoot the monitoring system. Just making sure that everything is going the way it's supposed to, you're getting accurate lines, you're getting accurate readings, and if you're not, fixing that issue. Okay guys, so bear with me on this one. I didn't type it all out the way I have the others. I'm just gonna go through my notes and tell you the important things that I am going to study. So for your pulmonary artery pressures, this is the one that enters through the subclavian, goes down through your right atrium, right ventricle, and up into your pulmonary artery. This can measure cardiopulmonary function and fluid status. This is the one that Ms. Davis brought to SimLab. So this gives you venous and arterial access and does hemodynamic monitoring as well. So complications that can occur because of this, obviously infection. These are a lot the same as your CVP. So pneumo or hemothorax, air embolisms, atrial and ventricular arrhythmias. This is specific to PAP because it can irritate those nodes in the heart to cause arrhythmias. Cardiac perforation, this catheter is in your heart. Misplacement can give you wrong readings. Artery perforation, it is inside your artery, so it can obviously perforate that. A pseudoaneurysm or a thromboembolism if it clots off. So pulmonary artery pressure monitoring is indicated for heart failure support for the hemodynamically unstable patient. It can direct to your med use, such as volume replacement, vasopressors, inotropics, and vasodilators. We measure this to balance the O2 supply and demand. and we use it for all high-risk procedures such as CABG or aortic aneurysm repairs. So there's several ports. Your first port is inflated in your right atrium, so you can measure pressure there. Your second port is in the pulmonary artery. And sometimes you can give meds through these. It just depends on your doctor. So it measures pressures in your right atrium and right ventricle and pulmonary capillaries. You can only measure the right ventricle pressure on insertion, not for the whole time. Your right atrium is measured from your proximal port, and your pulmonary artery pressure is measured from your distal port. The right atrium can be continuously monitored, but your pulmonary artery can only be intermittently monitored because to measure that pressure, you have to occlude the artery. This is the one where it's really important not to change out the syringe that comes with the set, because if you inflate the balloon in the pulmonary artery too large, then you can burst the artery, and that's not a good deal. So that is all I have for those. Okay, so we're going to skip a few sections that I will cover in the next video. There will be 4. I did not realize how long these would get. So for the next section we're going to cover is cerebrovascular disorders. There are 5 questions over this. This is going to be your strokes and your brain tumors. So we'll go over those. First, we're going to talk about your lobe function. We're just going to talk about the 4 biggest ones. We have your occipital lobe, which is in the back of your head back here. It covers visual processing and object recognition. We have your temporal lobes. Those are up here. Hearing and language understanding, so audio stimuli interpretation, memory, sequencing, meaning and learning are all parts of your temporal lobes. Then we have your parietal lobe. It's right up top here. Nerve impulse processing, so pain, temperature, touch, space perception, spelling, calculation, body position. Those are all things that are controlled by your parietal lobe. Then we have your frontal lobe right up here in the front. Motor control, motivation, judgment, and decisions. It's also linked to emotion, creativity, and planning. Now we're going to talk about brain tumors. We have primary and secondary. Your primary originates within the brain itself, and your most common is astrocytomas. Your secondary cells from outside the brain migrate to the brain, and your most common is gliomas. So tumor risk factors. We have genetic mutations can cause this, or deletion of the tumor suppressor gene. We have inherited diseases, which is neurofibromatosis or retinoblastomas. Your environmental, such as vinyl chloride. This is on everything, guys. Pipes, wire coating, cars, furniture, so much stuff. Radiation. So basically, if you have had a previous cancer or childhood cancer, you are more at risk for a brain tumor. Medical management of brain tumors, we have chemo, radiation, and then pharmacological management, we're going to give them a glucocorticoid. The one of choice is Decadron, or it's also known as dexamethasone. This is for treatment of symptomatic cerebral edema. We can do some surgeries. They have the ESBS, that's the one that goes up through your nose, and you have an increased risk of meningitis from this. The craniotomy, they will remove a segment of your skull. We'll talk about this more in a minute because we're going to talk about nursing care post craniotomy. Brain mapping, that is just something they do to avoid areas that involve motor and speech. Um, and stereotactic surgery, that's the gamma knife. It's not surgery in the traditional sense, but it's like multiple rays of radiation hitting the same point all at once. So, nursing management of the patient with brain tumors is enhancing comfort. Codeine is the drug of choice for pain. Providing nutrition, we need to check their swallow gag reflex. Um, and just know that their pre-surgery symptoms may continue following surgery. The brain is a strange organ. So communication, they're going to have sensory deprivation and they'll probably be intubated. So you're going to try to establish a baseline before they go into surgery and continue using that until they are extubated and communicating more freely. Then we're going to keep them safe. These will be fall risk patients, and we're going to collaborate with therapy, physical therapy, occupational, and speech to improve their safety. So complications from surgery and the brain tumor, you've got DVT, the usual risk factors with that, along with malignant tumors increase the risk of DVT, and if their tumor was large, their surgery was longer, so that can increase their DVT risk as well. Then we have your CSF leak. This occurs due to a dural tear. This will present with the halo sign, which is the drop of blood with the clear ring around it. Their headache will be worse when they're sitting up, and this is something that typically heals on its own. Just monitor to make sure that it doesn't get worse. Other complications could be meningitis, seizures, and their recovery could just not go well. So we're going to move on to strokes. The signs and symptoms of this are headache, mental changes such as confusion, disorientation, and memory impairment. Respiratory, they could have decreased respirations due to decreased neuromuscular control. Cough swallow reflex will be decreased. The agnosia, that is their decreased ability to interpret sensations. Incontinence, seizures, hemiparesis or hemiplegia, emotional lability, visual changes such as the hemanopsia that we learned about in class, where like peripheral on one side or the other, will be not working as well. Horner syndrome, that's the ptosis of the upper lid, which is just, and I will demonstrate, but like when one is drooping more than the other. Vomiting, perceptual defects, and apraxia. This is their decreased ability to perform learned movements, such as like doing this or other things like that. So risk factors for stroke are age, hypertension, AFib, cholesterol due to plaque buildup, increased insulin resistance, and obesity. The obesity is typically because sedentary lifestyles lead to increased clotting. So for your right strokes, your right-sided strokes affect the left side of your body. So you'll have left-sided paralysis. And then spatial perceptual deficits, they minimize their problems. They have a short attention span, visual field deficits on the left side of their body. Impaired judgment, they will be impulsive and have an impaired time concept. For their left, the left strokes, you're going to have right-sided paralysis and visual field deficits, impaired speech and language, slow performance. They will be aware of their deficits, and this causes depression and anxiety in these patients, and they will have impaired comprehension. So for our pre-hospital stroke scale, also known as the Cincinnati, You will check for facial droop, arm drift, or altered speech. If any of these are present, they are having a stroke, take them to the hospital. For assessment and diagnostic criteria, we want to know when were they last well and provide fast and efficient care. We are going to do a focused history and neuroassessment. We're going to do the NIH scale. We're going to ask them about recent surgeries and what medications they are on. We're going to get a CT without contrast to rule out hemorrhage. We're going to get a CTA to find the location and size of the clot. We need the first CT within 20 minutes of arrival to the emergency room. We're going to do an EKG to check for myocardial infarction, and then we're going to run labs: glucose, CBC, CMP, PT-INR, and cardiac enzymes. The cardiac enzymes are to rule out the myocardial infarction. Glucose is to rule out hypoglycemia. Then nursing management of these patients, they need an airway, so always be monitoring the airway. We're going to put them on telemetry. Take their blood pressure. Our goal is less than 185/110. Our preferred drug of choice for high blood pressure is labetalol. And hyperthermia is also something that could happen, and we're going to give them Tylenol to break that fever. TPA is given for ischemic strokes. I did not cover that. Ischemic is a clot, hemorrhagic is a hemorrhage. So TPA is given for ischemic strokes. This restores blood flow and limits infarction volume. You give it when they have not, like when the CT says no hemorrhage, their blood pressure has to be below 185/110, glucose between 50 to 400, and a diagnosis of ischemic stroke with neurological deficits within the previous 3 hours. The dosage for TPA is 0.9 milligrams per kilogram. You give 10% of that dose as a bolus, and then the rest of the remaining 90% you infuse over the next hour. Review the inclusion criteria on your own. I'm not going to go over it. Basically, if they've had major surgeries, traumas, urinary or gastrointestinal bleed, taking heparin, pregnant, under 18, they don't qualify. The main complication with TPA is that they will have a hemorrhagic conversion. So they will have come in with an ischemic stroke. We gave them TPA, and now they're having a hemorrhagic stroke. This presents as hypotension and hypoperfusion and occurs in 6% of cases. So they can also manage ischemic strokes with surgery. They can do arteriothrombolysis, which is the catheter injects TPA directly into the clot. They can do an embolectomy where they insert a catheter and retrieve the clot. They can do a carotid endarterectomy, which isn't seen very often, but they cut open your carotid and pull the plaque out through there. Or they can do a stent placement and just push the clot up out of the way. Now we're going to talk about cerebral and subarachnoid hemorrhages. The ICH, intracerebral hemorrhage, is 41% of hemorrhagic strokes and commonly causes hydrocephalus. Then we have your subarachnoid. Aneurysm rupture is most common, and the people at highest risk are women, smokers, and people with hypertension. What we're going to do with this is they'll have vasospasms following hematoma removal. So they treat this with calcium channel blockers prophylactically for 21 days to prevent it. And then we're going to do volume replacement to increase their blood pressure to reduce the chance of vasospasms. Hydrocephalus is treated with drain placement, and their cognition should improve dramatically after this is placed. Okay, so that is all for this video. I will finish covering the other material in a third video and cover the new material, sepsis and burns, in a video all by themselves because they make up 18 questions of the final. So I'll go more into depth as if it was a like a unit exam. I hope these are helpful.